Good afternoon, dear colleagues. It's my pleasure to welcome you to this new PCR webinar. We would like to update you on tricuspid interventions, on patients suffering for tricuspid regurgitation and how we treat them optimally. And we want to discuss with you from the procedure up to follow-up. And if you join us for this session, we would like to discuss with you first of all, the 2 years data of the Triluminate pivotal trial, which have been just recently published. We would like to understand with you together the selection and the indication for tricuspid repair after a period of initial medical and conservative management, as done in the Triluminate pivotal trial after 1 year. And hopefully we can describe at the end of the session better the clinical patient pathways pre and post tricuspid procedure. We'll do that with an excellent team. We have 3 very well reputed interventional cardiologists on board who will discuss this agenda with you. First is Saibal Kar from the United States, Los Angeles. He will cover with you upfront the Triluminate pivotal 2 years data. Then we have Julien Dreyfus from Paris here in France, also an esteemed cardiologist who will discuss a case with you. And then at the end, he needs no further introduction, Philipp Lotz, Professor Lotz from Mainz in Germany. He will also present and share a case with you. We will go into the agenda right away, but first of all, let me remind you that this session is meant to be very interactive, so there is a chat ongoing, and if you have any questions to us, please ask them, and we will try to answer them during the course of the session. And now, with no further ado, I hand over to Saibal Kar. He's He's connected remotely from Los Angeles, and he's going to share his view on the data of the Triluminate pivotal trial after 2 years. Saibal, it's our pleasure to have you.
Thank you very much. On behalf of PCR webinar, I'm honored to be presenting the 2-year outcomes of the transcatheter tricuspid valve edge-to-edge repair, the 2-year follow-up, the Triluminate trial, on behalf of all the investigators. These are my disclosures. How important I served as the chairman of the steering committee of the trial. So the Triluminate trial was the first randomized controlled trial to evaluate edge-to-edge repair in patients with symptomatic severe TR despite optimized medical therapy. The primary endpoint evaluated at 1 year showed that TR with TriClip was superior to medical therapy alone, driven primarily by improvements in health status with no differences in mortality or heart failure hospitalizations. However, there was a favorable trend in heart failure hospitalizations with subsequent enrollments in the 1-year data. This slide shows you the total of 572 patients who were enrolled in the trial, and then they were randomized equally to control and device. And then over here, you can see what I'm showing today is the 2-year visit completion, 207 patients in the device arm. Then there was 142 patients who crossed over and 57 who actually remained as a pure control. The pre-specified 2-year endpoints, intention to treat, was recurrent heart failure hospitalizations through 24 months and freedom from all-cause mortality, tricuspid valve surgery, and tricuspid interventions at 24 months. In addition, I'm going to show you some adverse events, TR grade, and improvements of health status. The baseline characteristics was shown previously, but just to put it in perspective, these were aged group of patients, 78 being the average. Torrential tricuspid regurgitation, classified by the 5-grade scoring system, was present in almost 50% of patients, and functional tricuspid regurgitation was the majority cause of TR. Of importance, these patients, the ejection fraction was preserved. They were primarily HFpEF patients. Now, this is the TR grade as a paired severity, and what you can see over here clearly by intention to treat, in the device arm, you can see there was stability of repair. 84% were moderate or less at 2 years, and this remained consistent. Now, in the control group, as you can see at 1 year, there was actually worsening of tricuspid regurgitation, and then at 2 years, you can see about 50% had become moderate or less. And this was primarily driven by the patients who had crossed over. When you look at the pre-specified endpoint of heart failure hospitalization, as you can see, there were 127 events in the control arm, which give you an annualized heart failure rate of 0.26. Next slide. And you can see in the next slide, there was a reduction of hospitalization. The hazard ratio of the pre-specified joint frailty model was 0.72 with a one-sided confidence interval of 0.93, which gave a p-value of 0.02. Of importance, this resulted in a 28% relative risk reduction in heart failure hospitalization with the different device. Of importance, when I analyzed the data using a two-sided confidence interval, it was also statistically significant with the confidence interval between 0.53 to 0.98. This confirming that there was an improvement of heart failure hospitalizations in spite of the crossover. Now, if you look at the second endpoint of freedom of all cause mortality, surgery, or intervention, 77% of the patients were free of any of these interventions in the device group. On the other hand, on the control arm, there was almost 26% were free from mortality, surgery, or intervention. And this was primarily driven by the fact that most of the patients in the control arm received a TriClip in the second year. There was no difference of importance in mortality between the two groups at 2 years, and there was no difference between the need for tricuspid surgery. The safety of the procedure is very important. And as you can see, if you look at this, the device arm, you can see that stroke and TI were very small. Conduction disturbance throughout the 2 years was only 5.5%, and device embolization was 0 and device thrombosis was 0. Now, what is not in this slide is the single leaflet detachment rate, and that was around 6%. And most of these cases, almost all, were at discharge or by 30 days. There was no cases of late single leaflet detachment. Now, I would like to show you a bit on the crossover analysis. In the crossover analysis, you can see the patients who crossed over, which was 142 patients, their tricuspid regurgitation became more severe. They had more heart failure hospitalizations prior to crossover, and they were more symptomatic compared to the small group of patients who did not cross over. This is the tricuspid regurgitation grade of a crossover. As you can see, the device arm did pretty well, and at 84% in moderate TR. The crossover patient also did well. As you can see, at 1 year, they had worsening tricuspid regurgitation, but by 2 years after crossover, 82% or 81% was moderate or less. But there was a small group of patients, 44, which did not need to be crossed over and did well on medical therapy. And you can see in this slide that 21% of these patients became moderate or less by 2 years, and also less became torrential. And this has an importance in the understanding of the pathophysiology of this disease. Now, this is important to understand the health status through 2 years. There are 3 graphs. The green line represents the device arm, and you can clearly see that there was a significant improvement of quality of life at 1 year and persisted to 2 years with a reduction of TR. The red line represents the patients who crossed over. And you can see over here, at 1 year, they had worsening TR and practically no improvement of quality of life. But after 1 year, they actually crossed over, and there was a significant improvement of their quality of life at 2 years. And there's a small group called the pure control, which remained stable on medical treatment, showed a moderate improvement of quality of life, which persisted till 2 years. And that group also showed an improvement in the TR, which tells you that there is always this is a functional disease, and there can be some improvements with tricuspid regurgitation, with medical therapy, with improvement of quality of life. And finally, this is my conclusions. At 2 years, the treatment of TriClip device reduced heart failure hospitalization compared to medical therapy, despite crossovers in the control group. Of importance, a crossover procedure was not counted as a heart failure admission. Improvements in TR severity and quality of life were sustained in the device patients through 2 years. The TriClip therapy is safe through 2 years and even on crossover. The control patients whose symptoms and health status had worsened prior to crossover benefited from the TriClip device with improvements of TR severity and quality of life. I'd just like to add my last 2 cents. I would like to acknowledge the principal investigators, the steering committee, the research staff, the sponsor, and of course, the patients. And this was actually, the full manuscript is available in circulation and will be soon in paper in the next month. Thank you very much.
Thank you very much, Saibal, for this excellent overview and this spectacular data. Maybe I can ask you a spontaneous question. You have shown us the baseline criteria after 1 year of the crossovers versus the non-crossovers, and there was quite a significant difference between the two groups. The crossovers were sicker, they had more New York Heart Free, they had more diuretics, and they had more torrential tricuspid regurgitation. So expectedly they crossed over. But how about the baseline criteria at the beginning of the study? Could you have predicted at the beginning of the study who would have crossed over after 1 year, or is that not possible with just the regular parameters we have?
So thank you very much for this very important question. Obviously, that's the first question that anyone will ask, that can you predict who will respond to medical therapy alone versus TriClip? Based on the traditional criteria that was used, severity, RV pressures, RV function, demographics, there was no obvious difference between these 3 groups at baseline. However, we did not do very detailed analysis of the anatomy of the tricuspid valve, and potentially there could be differences in the anatomy which would tilt us to one group or another.
Okay, so there could be data to come. So, Philip, you have seen this very impressive 2 years data about this endpoint diverge. What do you think about heart failure rehospitalization rates? Is that an important endpoint for clinical trials and for the patients?
For me, it is. I strongly believe that it's a very important endpoint. Obviously, it puts a lot of burden on the patients. It is costly, but most importantly, it is related to mortality. There is a reason that it's called a heart clinical endpoint, so it's more objective than softer endpoints. The only difference to studies and areas where we focus more on left-sided heart failure is that maybe in right-sided heart failure, patients present a little bit later at the hospital because having peripheral edema does not come with that much suffering as pulmonary edema. So that would be the only difference I think is important to consider when comparing heart failure hospitalizations in the context of left as opposed to right heart failure. But also in patients with TR, for me, it's a very important endpoint.
So maybe in future trials, we should also not only include in this endpoint hospitalization for heart failure, but maybe we should use this term worsening of heart failure, which would also cover these patients which have increasing edema and which show up in the outpatient clinic and get an increase in their diuretics?
Yes, probably, and that also has been done in other heart failure studies. That is not only the hospitalization, but also the necessity to increase diuretic dose, for example.
So, Julia, if we have seen this decrease in heart failure hospitalization, which is not a surprise to us because we are all enthusiasts about this therapy, would you think that this should be followed also by a mortality difference?
Yeah, sure. For me, there is a continuum in the disease, and as mentioned by Philippe, the patient at the beginning is asymptomatic, and then unfortunately symptoms are quite aspecific, and then you will have peripheral edema and sometimes heart failure, not always, but sometimes. But when you have heart failure, it's the beginning and you are getting closer to death. So yeah, for sure, once we are going to show any survival difference.
And maybe there's a question from the chat. I apologize because Saibal, it's not an easy question. Is TriClip indicated for patients with pulmonary hypertension due to sickle cell anemia? What is your perspective on
this? That's a difficult question, but I think between replacement and repair, I think the TriClip will be a safe treatment option, or actually any form of repair, even in the presence of pulmonary hypertension. Even though I have to acknowledge that we excluded patients with pulmonary vascular resistances of greater than 5 or a pulmonary PA systolic pressure greater than 70, but patients with moderate pulmonary hypertension were included. And at the present moment, we are treating patients with moderate pulmonary hypertension.
So what, Julia, maybe a spontaneous question as well. What would be your take on pulmonary hypertension besides sickle cell anemia? Would you treat this patient, or is this an argument maybe not to treat a patient if other arguments pop up?
There are several points to assess. The first is to be sure that there is no precapillary hypertension. That's the first point. It's rare, but it happens. So we have to be sure that there is no such situation.
So sorry for interrupting you. So if there is pre-capillary hypertension,
you
would refrain from...
Exactly. You have to refrain if there is pre-capillary pulmonary hypertension. If it's post-capillary pulmonary hypertension, usually you can treat those patients with diuretic and sometimes other drugs, and you could decrease this. And what has been suggested in all studies is not to treat patients with severe pulmonary hypertension. If you look, for instance, in the guidelines for the surgery, it's written if the patient has severe pulmonary hypertension, it's also a contraindication. So it should be a contraindication for both surgery and transcath there. But if it's only post-capillary, usually with treatments you are able to decrease it, not to make it normal, but as mentioned by Sebel, to decrease it, and I think that it's not a contraindication if you are able to decrease it.
If I recall correctly, your group has published a paper on this pulmonary hypertension patients. Would you like to comment on this?
Maybe I see it slightly less strict. I think we have to be a little bit careful because we know when there is a significant precapillary component, then outcome is inferior as compared to no pulmonary hypertension or compared to isolated postcapillary. But we don't have a control group because we don't have a randomized trial in there. And what the Kaplan-Meier curves often show is that sicker patients have inferior outcome. And that's certainly true for patients with precapillary pulmonary hypertension. Some have been treated, and in some experience dramatic clinical benefit, symptomatic benefit. So anecdotally, some can benefit, and I would leave the door open for a little bit longer, also in patients with precapillary pulmonary hypertension.
But yeah, there's another question, but maybe, Saibal, we can stick to this pulmonary hypertension for a second. You mentioned already this repair versus replacement issue, because we have always this fear that we have an afterload mismatch if we have an increased afterload with precapillary hypertension. So would you make a different decision concerning replacement versus repair in this type of patient? First question. And second question from the chat, what would be your cutoff from PVR where you would not treat a patient?
So from the clinical trial, I'll answer the second question first. From the clinical trial perspective, a pulmonary vascular resistance of greater than 5 Wood units was the cutoff. That's quite high, actually, PVR of greater than 5. So that I would still stick to that. The second question about repair versus replacement, we do know that when we repair a valve, mitral or tricuspid, especially with edge-to-edge repair, we do maintain the RV/LV function. So I don't think there'll be a significant RV mismatch if you suddenly reduce the TR. And when you do TR, we've seen this, that the patients are left with moderate TR or mild TR. They don't have post-procedure hypotension. Unlike when you do a replacement, there's a small group of patients who require inotropes, right, post-support. So that's why I think that this afterload mismatch issue will be less likely to occur after a TriClip or tricuspid repair compared to replacement.
Yeah, I think we all can agree on this. I think we should move on to the next presentation. Julien brought a case from his place, from his hospital, of a typical patient which could have been randomized in the Triluminate trial.
Exactly. Thank you, Georg. Yes, it's a typical patient. An 86-year-old female was very symptomatic, being in NYHA function class 3, presenting with signs of right heart failure. Despite high dose of diuretics, the TRI-score was high, as it was 6 out of 12 points. TR was severe with an error of 60 millimeters square. The mechanism was functional atrial tricuspid regurgitation due to chronic atrial fibrillation with tricuspid annulus diameter that was 43, meaning a dilated tricuspid annulus. TE showed a nice 3 leaflets valve, nicely shown with both the 2D transgastric view and the 3D. So for this patient, the strategy that was chosen was a clover strategy, meaning one first clip between the anterior leaflet and the septal leaflet, and a second clip between the posterior leaflet and the septal leaflet. And here is a summary of the procedure with the first clip between the septal and the anterior leaflet, with here the grasping of both anterior and septal leaflets. Then the release of the first clip to check that the clip is well attached to the 2 leaflets. Once released, we implanted a second clip between the posterior leaflet and the septal leaflet. And at the end of the procedure, the result was excellent, with 2 clips that were well attached, as nicely shown with all 2D and 3D views, with an excellent final result and a trace residual tricuspid regurgitation. At 6 months, the patient described very significant improvement for a functional status, as she was NYHI function class 2. She doesn't present any more signs of right heart failure under the same dose of diuretic. Transthoracic echo confirmed the excellent results, with once again the 2 clips that were well attached. Still trace of residual TR, a mean gradient of 2. The tricuspid annulus diameter significantly reduced from 43 to 37 millimeters in the apical 4-chamber view, and the inferior vena cava was seen and compliant. So the result that we would like to expect for any patients.
Yeah, wonderful. Thank you very much. Really excellent result. Maybe just a quick question to Saibal. What was the average number of clips used in the device arm, and which clips were used predominantly? Do you have that from the top of your head?
Yes, I think it was 1.6 to 1.7 clips per patient, and the majority was XTW or XT.
Okay.
And in fact, if you remember, you guys were all on the committee. In the initial, when we started the Triluminate trial, I don't think XT and XTW were available. Remember? It was only started a bit later. And I think if it was available from the beginning, it would have almost become 95% XT and XTW.
Yeah, I was about to ask you, Philip, is there any reason in the tricuspid space not to use a large and wide clip?
Almost none.
Beginning.
Almost none. Because, I mean, the reason why it works is that you increase the coaptation length, and therefore you need to get as much tissue in as possible. It probably also reduces the stress on the tissue. It reduces the risk of late failure. It makes the procedure more effective. So for me, using the larger clips and getting as much tissue in as possible is the way forward.
And maybe we stick a bit to the technical aspects of the procedure. You have chosen this Clover technique in this patient. Is this your preferable approach? And if so, why?
Whenever possible, yes, we prefer the Clover technique because we believe that by treating the anterior part but also the posterior part of the annulus, you will be an effect on the annulus, which is the goal, not only on the leaflets. So yes, we truly believe that whenever possible, we have to use the Clover technique, but we are also aware that I showed the best case with 3 well individualized leaflets, which is not the situation that we face every day for all patients, and that when you have more leaflets, it may be much more difficult to perform this type of intervention.
I know that you advocate, Philip, a bit more the anterior septal approach. Maybe you can also comment on this technical issue?
Just to keep it simple, I think what you said is very important. You need to get an indirect annuloplasty effect by edge-to-edge therapy. This is why it works. And sometimes you need Clover techniques. Sometimes you can achieve the same with implanting multiple devices between anterior and septal only. Anterior and septal only is probably the easier approach to start with when going through the initial learning curve, and it's probably also the approach when it gets more and more complex in the anatomy. Keep it simple is always a winner, I believe, and that's why I try to stick with anteroseptal. But obviously, if you don't get out the result you desire, then you have to change the strategy.
Okay, so in this type of patient, how would you proceed with your medical treatment afterwards? How about diuretics, for example? What would be your recommendation?
This is a very important question because frequently other colleagues at the center are asking for this question. What we are doing usually is to keep the same dose of diuretics. What we say is that RV dilation occurred with a long time, and that RV remodeling will take also several months or year. It's what I've been observed from several studies, including EuroTR. So what I would say is that we should keep the same dose of diuretic at least for the 6 first months following the intervention, and then we will see according to the functional status of the patient, according to the inferior vena cava, and there are probably even more parameters to show congestion that we don't know yet how to use in daily practice to adapt. So to give a very simple message, I would say that we should keep the same dose after as we used before, at least for the first month, and then we will see over time.
And Saibal, could you maybe comment how the regulation was in the Triluminate study? Should the patient stick to the diuretic dose in the treatment in the device group, or how was it? How was it done, and do we know how the treatment evolved over the first year?
Yes, we do have that data. And in the paper, you actually have a supplement section showing you the changes. And what it was found in the device arm, it remained consistent. That means we didn't reduce it and we didn't go up. In the control arm, on the other hand, the patients became more sicker and the diuretics went up. So I think, I totally agree with Julian that you should continue the same diuretic dose in medical therapy, and only many months later, when it's remodeled, you may consider changing. One other medication which I would like to mention, which was not taught in Triluminate too much, is SGLT2 inhibitors. Because these are HFpEF patients, the percentage of patients which were used in the trial was very small because it was not easily available. Otherwise, I personally now put most of these patients on SGLT2 inhibitors in addition to diuretics. I think it should be given.
I think we can agree on this, although there is no data on patients with tricuspid regurgitation so far, but it's our...
I mean, these are HFpEF patients, so...
Same practice we have. And Philip, how about renal function and the correspondence to diuretic therapy? I mean, one notion could be that you start to decrease diuretics because you have the risk of deterioration of kidney function over time. What is your perspective on this? And do you have experience on an increase in kidney function, a benefit on kidney function after tricuspid regurgitation treatment?
At least there is a lot of hope that kidney function can improve. I mean, for the kidney function, the arterial pressure does not matter as much as venous pressures. And as long as you succeed in reducing central venous pressures, then in some patients you can expect improvements in renal function. There's one study in which it was actually shown that the renal function stabilizes after treating TR. but worsens in those who were in the control group. It wasn't randomized, but it shows that in these patients it's very important to have some sort of control, because stabilization, so not worsening, could be already a success. And if you obviously only look at baseline to follow up, then you might miss these benefits which come with the procedure. I think it cannot be stressed enough what you said also before, that because normally the approach is to reduce diuretics, maybe by the patient, maybe by the GP, maybe by somebody else who is treating the patient after a transcatheter treatment of TR. And this is always a bad thing. It is always a bad thing. Diuretics should stay the same level, or maybe need to be increased if needed. But to go back to your initial question, there is a good chance that renal function gets better after treating TR, yes.
I'm not aware of systematic data on this. Has this been published?
Not in it's not published yet, but we do have the analysis. We have also presented it, and we should publish it very soon.
Okay. So Saibal, one question to the crossover patients. Did you see any evidence for end organ or increased end organ damage? Do you have this data maybe already available on kidney, on GFR, on liver function or something like this?
I don't have it. I'm sorry, I don't have it in my initial analysis, but we are going to show that, because I think there was one paper already shown, published in JACC, showing the improvement of some renal as well as hepatic functions after TriClip. But I don't have a comparison between the control and device over 2 years. And we will have this available. And I think I agree with Philippe, we will definitely show a difference. I'm nearly sure there will be a difference.
Maybe one follow-up question, and let's shift gears for a second. You have shown us this beautiful data also on the non-crossover patients, and we all noticed that 80% of these non-crossover patients were still suffering from severe to torrential tricuspid regurgitation after 2 years. You showed that in that bar graph. But still, the patients were doing okay. They had also an increase of KCCQ by 10 points after these 2 years. So maybe a provocative question, is improvement in KCCQ score not always related to TR severity, or what is your take on this?
Well, I think it was a very nice graded score, because remember, 22% of the patients became moderate tricuspid regurgitation, right? Compared to 0 at baseline. So obviously, those patients who went to moderate TR drove the improvement of quality of life. So that it just proves to me, we have now 3 groups of patients, right? One who did worse, one who did well, and one who did much better in device. And there was a clear-cut correlation with quality of life. The device arm, which had a reduction of TR from the very beginning, had the greatest quality of life. The crossover arm, which did badly at 1 year with significant reduction of quality of life, showed an improvement after TR reduced, and the medical arm, which stabilized, and actually there was a moderate improvement of TR, showed a moderate improvement of quality of life. So there's a clear-cut now graded correlation between reduction of TR and improvement of quality of life. And that reduction of TR can come from any means, whether it be medical therapy or device therapy. Now, there could be a threshold that you don't always have to become trace tricuspid regurgitation. Maybe mild to moderate is okay.
And there is a question from the audience, and maybe to Philippe. It relates to somehow also to the topic we just discussed, because it brings RV function into the game. I mean, it could be also a patient with torrential tricuspid regurgitation still having slightly preserved or just mildly impaired RV function, maybe not being so symptomatic. That is just a pure speculation, but the real question from the chat is there any cutoff for RV systolic function for patients to be treated with a repair device, or specifically for the Triluminate trial?
It's a difficult question. What's probably more clear is the fact that whenever you assess RV function, you should not only rely on longitudinal parameters, not only on TAPSE, but ideally use some global parameters like ejection fraction derived from 3D echo or CT or MR. And there a cutoff value of 45% ejection fraction has been established where the Kaplan-Meier curves divert. However, that doesn't mean that patients in the lower ejection fraction group cannot benefit from any treatment. With replacement, I'd be slightly guarded in patients with an ejection fraction, right ventricular ejection fraction of less than 45% for sure. With repair, it is not a relevant problem in reality. Even really bad RVs tolerate repair very well, and that's completely different to what everyone was speculating on when we started the therapy many years ago. But RV failure in repair, RV failure in clip implantation is not a clinically relevant problem, thank God.
So in your large volume center, how do you usually assess RV function, and what would you recommend? I mean, it has to be correct and reproducible, but feasible at the same time.
I fully agree with what Philippe said. First, assessment of RV function is very difficult, so we should use both multi-parameter assessment with transthoracic echo, but also multimodality imaging with transthoracic, with transesophageal when feasible, with CT and MRI, and probably even other options. That's the first point. About the cutoff, we don't have. 45 is usually given as the cutoff, but we don't know. And I would say that for me, RV function is not an important criteria to decide that a patient should be contraindicated for this intervention, as it may appear severe RV function after the implantation of a device, but usually it appears to work pretty well with no significant increase or decrease of the RV function. So I would say that for me it's not an important contraindication. I would focus more on pulmonary pressure, and I would say that the patient should be prepared before the intervention. It's what we are trying to do with intravenous diuretics the days before the intervention, and sometimes adding levosimendan or other drugs to prepare the patients. But RV function is, for me, is not an important contraindication for this type of intervention.
That raises another point, prehab, so to say. Do you bring in patients on a regular basis earlier to the procedure, a couple of days earlier, or do you deselect the patients?
I truly believe in it, and for us in our centers there is no patient. All patients come a couple days before to have intravenous diuretics to decrease the overload, to decrease the pulmonary pressure. We don't have a randomized study, so I cannot compare. I don't have evidence, but what we show is that at least there is no complication after, because what mentioned Sebel, and I think it's very important, is the safety. In fact, we are currently discussing about the results. Does it work on quality of life? Does it work on heart failure? And we need more data. We are happy to have Triluminate, but we need other randomized studies. We need other registries, and we don't have the data yet. But what has been shown is that it's safe, and for me, it's a very important message. We have to keep it safe. We have to prepare the patients to bring back the patients alive. That is one main difference with what has been shown with surgeries. The patient should be safe, and then we have to improve our data to discuss the best strategy for our patients.
Sure, and maybe Saibal, along these lines about the diuretics, and if we look again at this group which did not cross over, how long would you treat a patient, for example, with diuretics and look at a possible TR improvement before you decide on the treatment, on the interventional treatment? Is there a rule of thumb?
Yes, of course, the trial is different from real life slightly. I would treat a patient who comes now for at least 3 months of aggressive diuretic therapy. And usually, I actually do right heart studies on patients before procedure to confirm, as Julian mentioned, the pulmonary artery pressure, the pulmonary vascular resistance, make sure that the post-capillary wedge pressure is actually decreased appropriately, and the RA pressure is okay before I treat them. So I actually do treat them like that. And sometimes if I see the RA pressure is now down to 12, and the patient has severe TR. So I think there's no place for optimize anymore. I would treat the patient. So that's why I combined the therapy about 3 months. I do want to mention about something about RV function. I think that point that Philippe and Julian brought up is very important. In the Triluminate trial, it must be emphasized that RV dysfunction was not an exclusion. I actually checked it very carefully. It was not an exclusion. And so they were not worried about putting patients with severe RV dysfunction. It landed up not being there. We did not take patients too much with RV dysfunction, but that I think was not an exclusion. And the parameters that should be used, as you nicely said, it is a difficult assessment, especially in the presence of TR. And one of the methods of global and circumferential long strain is important, both circumferential strain and longitudinal strain.
Maybe, thank you. Maybe before we come to your presentation, just a statement on right heart catheterization before this type of intervention, mandatory?
For me, it's mandatory. You get an idea about the severity of TR. You know whether you need to prehab the patient. You get obviously all the information needed to assess pulmonary hypertension, to differentiate between pre and post capillary. It's complex enough finding the right patient, deciding on the right strategy. So all additional information is helpful, and I think with right heart cath we get a huge amount of additional information.
Okay, same for you, Julian.
Yeah, I fully agree. And your paper was beautiful, showing that even if I am an echocardiographer, to say that echo is not a good tool for patients with massive or torrential TR to assess pulmonary pressure, and you can assess right atrial pressure. So yeah, it's mandatory. No discussion about this.
Okay, so we need to move on to the next presentation. Now we have a patient who was randomized in the medical arm and had to suffer a while, and then was crossed over, and it will be presented by Philip. We're looking forward.
Exactly. So we're focusing on the conservative arm of randomized studies in the field of tricuspid interventions. An 81-year-old lady, typical risk profile. She clearly presented symptomatic NYHA class 3. She suffered of dyspnea, fatigue, and had quite marked peripheral edema. Her history also involved repetitive hospitalizations for heart failure, and as so many and almost all of these patients, she also presented with long-standing permanent atrial fibrillation. Her lab results showed some signs with increased of NT-proBNP, severely reduced kidney function, but normal bilirubin at that time. Left ventricular ejection fraction on echo was demonstrated to be still preserved. Also right ventricular function, there was some increase in systolic pulmonary artery pressures, and importantly, there was functional TR massive, so 4 out of 5. This is also illustrated here. You can see that the RV is not severely dilated. Function is still relatively good, but there is a clear sign of significant TR, which is again more clearly demonstrated here on the transgastric view. We do have a morphology, a tricuspid valve morphology consisting of 3 leaflets. You can also see, as done here and as we do in all our patients, a right heart cath was performed, still showing somehow preserved cardiac index, not a relevant increase in left-sided filling pressures, looking at these low wedge pressures. As demonstrated before, a bit of pulmonary hypertension, but no significant PVR. So overall, there is increased risk, as also demonstrated by TRI-score. She received 4 out of 12 points, which gives her an 88% risk of mortality for surgery. And then the decision was made that she is a good candidate also for the study. She was randomized, and she was randomized in the control arm. So after this randomization, the previous, the ongoing history is demonstrated here. So in the course of 1 year, she had 2 episodes of hospitalization for decompensation, and these decompensations, heart failure decompensations, were considered to be predominantly right heart decompensations. So she presented with peripheral edema, worsening of overall status, and also pleural effusion at that time. At 1 year after randomization, she was still in NYHA class 3, obviously did not get any better. NT-proBNP further increased and echo results remained unchanged. Also TR remained unchanged and again was graded as massive 4 out of 5. So at that time, the decision was made to cross over, and when I say the decision was made, obviously it was suggested by us and it was highly welcomed by the patient. She was very happy to then receive treatment. We treated this lady using the TriClip, starting with the first device going in intraceptally. You can see already on the right side of the echo image that there is good tension on the leaflets and probably also reduction in annular dimensions. And then a second device was implanted also intraceptally as demonstrated here. So this was not a clover technique, but 2 devices both going in intraceptally. And this was the final result again. Very good relief and reduction of tricuspid regurgitation. RV function remained preserved and she was doing much better following that procedure and after being allowed to cross over.
Well, thank you very much. Again, a perfect result, 0 TR, so to say. So maybe one question, so congratulations on this. One question, what did you do when she came back for heart failure rehospitalization in terms of medical therapy? You increased diuretics and just the usual stuff? Or?
We increased diuretics dramatically and obviously gave her IV diuretics to recompensate her and then discharged her with a certain increase in diuretics compared to what she had at baseline.
So, Saibal, maybe a question again to you. How about the endpoints in the non-crossover patients as compared to all the other patients treated with the device? We just discussed that. Is there an as treated, so to say, analysis? Because the heart failure rehospitalization you showed has been diluted by the patients who did crossover. The majority crossed over, so the result would have probably been much better if you would take out the crossover patients. Do we have any data or any idea on this or any speculation?
Yes, I would make a comment on that. Before that, I would actually like to congratulate Philip on that case. That is like a perfect result. I wish we had more results like that in Triluminate. Anyway, going back to your question on the as treated, even though we didn't show the graphs of as treated, you can extrapolate the data from what was given to you from the quality of life. You can see that the fact that the patients did no improvement of quality of life at 1 year in the ones who were the sickest, and they showed a 12-point increase with the quality of life at 2 years, tells you that if we did not have a crossover by 1 year and allowed it at 2 years, the difference would have been much more exaggerated, and we would have shown a significantly higher reduction of heart failure hospitalization. Considering the fact that the device procedure was safe both at baseline and crossover. For example, let's say you waited long and then you got a difficult scenario and the results were poor and there were more complications, then this would not translate into a successful story. But in our analysis and the example shown by Philip shows you that even if you delay the procedure, it's still safe and still effective. So I think putting this into fact, I think if we did a proper as treated analysis, which would be also required in the study, it was not pre-specified, we would have shown probably a clear-cut difference between continuing medical therapy versus a device therapy.
Yeah, very, very convincing. Maybe with the same token, Julia, the control group in the study, in general, but also in the Triluminate study, may not be comparable to a real-world control group because they are being seen frequently, they are being controlled, and therapy is reevaluated. Do you think that the control group is a proper group, or maybe the advantage of the device would even be greater
That is the issue of all randomized controlled trials. And it's exactly what I say to the patients when they are randomized in the medical group, because they are very disappointed. They would like to benefit from the device. I say, you are lucky because you are in the study, and even in the medical group, we will take care of you probably even more than we would do if you were not in the study. So for sure, the follow-up is not the same. And what we are seeing in the randomized studies in the medical group is could not be translated to real life, but it's also it does mean also that what we observe is probably the patients have less poor outcomes in the randomized studies than in a real life study. It means that when you are able to make difference in randomized studies, there are true difference.
Okay, yeah, I see that point. There's a question from the chat related also to the clipping technique. Maybe question to all three of you in Triluminate, but this applies also to the daily practice. Is there any selection based on the location of the tricuspid regurgitation jet, whether it is anteroseptal, in the anteroseptal commissure, whether we have a central jet? Maybe you start, Philip, and maybe Saibal, you take over.
Yeah, yes and no. I think it's slightly counterintuitive, because you would think that if the main TR jet is posteroceptal, then you can't go anteroseptally. It's yes and no. You still can go anteroseptal as long as you achieve an indirect annuloplasty effect by implanting the devices anteroseptally. You will pull over the RV free wall and thereby also reduce the amount of TR which is seen posteroceptally. It does not always work, and it very much depends on how many leaflets you have attached to the RV free wall. When there's more sort of almost a single leaflet, so only 2 leaflets of the tricuspid valve, which can also be the case, then you will get a massive indirect annuloplasty effect. When there are 4 leaflets, then it becomes much more complex. So as said, as a more simplified approach, starting anteroseptally, irrespective of where TR is, then see whether it helps also to get rid of posteroceptal TR is something I would recommend. And if it doesn't turn out that way, then you can still change your strategy and put one anteroseptal and one posteroceptal.
So Saibal, was there a predominant phenotype, so to say, in Triluminate, and a predominant location where the clips went?
Yes, the majority of the patients, as Philip had mentioned, were between anterior and septal. And as you said, that led to not only a TR reduction, but an indirect annuloplasty. Personally, most of the cases I've done are anteroseptal as my starting point. And usually it's better to do anteroseptal because it's easier than to do posteroceptal after. But if you do posteroceptal first, because of the shadowing, it's difficult to do the anteroseptal after. So we tend to do anteroseptal first. And if there's adequate reduction, otherwise, if there's more reduction, then we do posteroceptal too. Now, there are some circumstances where we've done posteroceptal only. Number one is if patients who are presented with isolated flail. So we had a patient who had a lead removal, and there was an isolated flail of the posterior leaflet. So the clips were only attached to the posterior and septal. Number two, sometimes which have just tethering, pure tethering near the commissure, near the posteroceptal, where I just put clips there. But otherwise, in traditional functional tricuspid regurgitation, putting anteroseptal first is quite common. And I think putting those clips more to the center is very important than rather being in the commissures.
And Julien, you would always put, even if you have already a satisfying result, you would always try to put a second clip for the annuloplasty thing into the posteroceptal commissure?
I truly believe that whenever possible we should, and that was Saibal mentioned. I think that in the early experience, when you asked to the industry partners, we were implanting 1.3 clips per procedure. Now we are closer to 2. So whenever possible, it's better to implant 2 clips, and it could be 2 anteroseptal or 1 anteroseptal and 1 posteroceptal. But I think the more efficient we are on the annulus, the best it is for the initial results, but also for the long-term follow-up.
Another question which popped up is about anticoagulation or antiplatelet therapy. How do we do that in repair patients, Philip?
They're almost all present with AFib, So they need anticoagulation anyway, and
If they don't have AFib?
very, very few, then we do dual antiplatelet therapy for 3 months. But this is so rare.
Okay. So in the Triluminate study, was there patients on vitamin K antagonist or on NOACs predominantly?
No, no one. There was a lot of patients with vitamin K and because of atrial fibrillation, but for the recommendation for the clip procedure, all that was required was single antiplatelet therapy. And I think a dual antiplatelet for a month. I don't even think for a TEER procedure you need dual antitherapy. I think you can just use just aspirin or Plavix or nothing. I don't even think you need anything. We just give it empirically, but I don't think it's necessary.
Yep.
And a lot of the patients who were in the study already had left radial appendage occluder devices, and those who had left radial appendage occluder devices did not require anticoagulation.
Sure, sure. So let's spend the last 1 or 2 minutes on the last question. It is about the selection between TEER devices, so repair devices, and replacement devices. There's a question here. Maybe we generalize it a bit more. What would be the patient, Julia, you would treat primarily with replacement or with repair? We need short answers.
Try to do it short, but it's like for surgery. First, the most important point is the mechanism of TR. Okay. First, you have to consider if it's functional TR or primary organic TR, because we are currently treating mostly functional TR, but there are also patients with primary TR. So that's the point. And I would say that the criteria that will go more for replacement than repair are first the size of the annulus. If it's very, very dilated with a large gap, we have said 7 millimeters or more. If you have a large gap, despite diuretics, it won't be possible to catch the leaflet. If there is an important tethering also, I would say that if I would like to make it very simple, it's the size of the annulus and the size of the gap. And the other point also is the number of leaflets. If you have many, many leaflets and you know that you won't be able to catch them efficiently with the clips, then you would prefer another option like replacement.
Maybe a question to you. What would be the patient you would primarily treat with replacement? Same?
Where I don't believe that I get a satisfying result with repair. And those obviously in which RV function is good enough for replacement.
Okay. And maybe a question to you, Saibal. If you have a patient who would be eligible for replacement and repair, what would you do?
If he's eligible for both, always repair. The best biological valve in the patient is his own valve. So whenever possible, preserve it.
Okay, I think that is a wonderful conclusion. Thank you very much to all of you. I hope you had also a nice discussion and a nice learning. I learned a lot, and I think the major bullet points for today are that tricuspid regurgitation patients suffer a lot. They are very sick patients with multiple comorbidities, and obviously we have now data that they benefit from tricuspid regurgitation repair measures, as nicely shown now in the Triluminate pivotal trial. We have now hard endpoint evidence with heart failure rehospitalization reduction, which is undoubtedly very important for the patient, but not only for the patient, but also for the society, because in the long run, it will help to reduce also costs. Remember, heart failure is the most expensive disease we have in the Western world due to the hospitalization rate, and any measure we can take to reduce this will also in the long run reduce cost. And the last message would be from my side and from all of our side, I think it's a very safe procedure, as shown impressively again by Saibal in the frame of the trial. The complication rate is almost zero mortality rate periprocedurally. So it's a procedure we can offer to the patients who suffer symptomatically from tricuspid regurgitation. With that, I would like to thank you for your attention, and I thank you, Philippe, Julia, and Saibal for this beautiful presentations and the discussion. And I hope you're going to have a wonderful evening. Thank you very much.
Thank you very much.